Hi, good evening everyone. So we won't waste any more time. We'll move on to the panel discussion part. Over the next 30-40 minutes, we'll discuss certain aspects regarding common neonatal practices, and we will make it for practicing pediatricians. We'll mainly concentrate on preterm care. So we'll just go through a case scenario and we will discuss whatever happens to the case. A 35-year-old primary mother was admitted with labor pain. She was almost 27 weeks old, 27 weeks of gestation. So, whatever things we expect from the gynecology part, or counterpart, for the improvement of the baby's outcome. Dr. Binu, can you elaborate on this?
Yeah, good evening everybody. Basically, to improve the neurodevelopmental outcome, we will be concentrating more on the antenatal steroids and magnesium sulfate. Now, this antenatal steroid thing has been for a long time, and now it has been proven beyond doubt that it's helpful for neuronal and lot of other issues also like PD, NEC and all. So the current thing is in 22 plus 6 optional. That is because we have to talk to the bystanders. We have to be very sure that they are really keen on the baby, because this is an age group which has a lot of morbidities. So before going to treat such a baby, we have to make sure that the relatives are with us. Now from 23 to 33 plus 6 fairly, nowadays most of the NICU units have started picking up more and more preterm babies. So the steroid given is betamethasone or dexamethasone, and the criteria says this can be given up to 34 plus 6 according to the RCOG criteria, and even the American ACOG criteria says 36 plus 6 weeks. But WHO says to be used with caution after 34 weeks. So the thing is, basically we give 2 doses of steroids, and then if there is a lack of delivery for more than 2 weeks, we can continue to give 1 repeat dose. So that is the current guidelines. And there, even though there are a lot of problems in the mother which can cause why a steroid should not be given, mother is leaking, mother has hypertension and all, there is no absolute contraindication to steroids other than hypersensitivity to the medicine. So that. Now regarding magnesium sulfate, now this has also been proven beyond doubt that magnesium sulfate antenatally reduces the incidence of cerebral palsy and also reduces death in preterms. But combined incidence of cerebral palsy and death hasn't shown much of a benefit. So if we look at the individually, they are both useful. Now the number needed to treat is 62. So if you treat 62 mothers with magnesium sulfate, one child benefits. Now there are a few trials on this, pre-mag trial, active magnesium sulfate trials, and the dosages given is 4 to 6 grams bolus followed by 1 to 2 gram per kg per hour. And the delivery should happen within 24 hours. That is, the delivery, like imminent deliveries, you give magnesium sulfate, and within 24 hours, because you cannot continue this infusion for a long time, it has its own side effects.
So in a nutshell, anyway, any baby, preterm baby who is less than 34 weeks to be born baby, antenatal steroid has to be given. Regarding magnesium sulfate, before 30 weeks, it has to be given. So the next question is, which antenatal steroid is better? If you ask different gynecologists, they will have different opinion. Beta is better, Dexa is better. So it is something like asking who is a better actor. So what is the evidence? What is your evidence, Dr. Binu? Sorry,
yeah,
Dr.
Yeah, thank you, Dr. Nelby, and good evening. Just I want to know from the audience, how many of your units are using beta? 1, 2, 3, 4, 5. How many of you are using Dexa? Nobody are using. So it's presumed that the other people are not working in birthing center. Okay, fine. So this both steroids can be given. It's just like asking who is better, this Mohanlal or Mammootty, who is better. You ask the Malayalis, there will be difference of opinion. But still, what is the evidence or what is the science behind that? if you see this, I would like to reframe this thing as like this dexamethasone to betamethasone, like dexamethasone sodium phosphate to betamethasone acetate plus phosphate. So what is the problem with this betamethasone which is available in our country? Is that the salt which is available in our country is betamethasone phosphate. So only this combination salt is available in India, which is not heat stable. So if you keep in room temperature or a high temperature, it is heat labile. So the efficacy will come down with this if you use this betamethasone phosphate only. So if you use dexamethasone sodium phosphate, which is again available in our country, as this salt, its efficacy is good. So the only problem with the dexa is that you have to give 4 doses, as you know, 4 doses. If you are giving this combination salt, you need to give only 2 doses, total 24 milligram. So that is the thing. So whoever is good, both are good, but the thing is that those units which are doing this betamethasone, they should switch over. If you are doing this 4 doses, it's okay. But if you are using DEXA, again 4 doses are okay, but this efficacy is more. And also the dexamethasone is there in this WHO essential drugs list. It is heat stable and it is recommended by the Government of India. And again, one more point to add is that dexamethasone is comparatively cheaper when compared to betamethasone. So that is the thing. So if you ask me which steroid you will prefer, the answer is dexamethasone. As it is recommended by the Government of India, it is heat stable and it is as efficacious as beta, the combination salt of beta, which is not available in our country.
So, from Murali's description, it's very clear it has to be dexamethasone, not betamethasone, if you are practicing in India, because betamethasone salt is not available in India.
So who is going for Mohanlal and who is going for Mammootty? Nobody. Very good.
So this concerned baby, antenatal steroid was given, dexamethasone was given, and baby was delivered by normal vaginal delivery, and both antenatal steroid as well as Maxel was given. So what all things you will do after delivery, immediate newborn period, that is the most important time of the baby, which will decide long-term prognosis. How will you manage clinically and in your practice, Dr. Vishnu, how will you manage?
Thank you, Nelby. Very good evening to all. So, apart from the neuroprotective strategies that we were discussing, antenatal magnesium sulfate and steroid, so dictum is in the immediate postnatal period is gentle care. So gentle care of a newborn, especially a preterm, starts rightly from the delivery room itself. So you initiate resuscitation in room air. In preterm, consider resuscitating in 21 to 30% of oxygen. So before that, if we are dealing with a preterm in our center, do have a blender and a delivery room TP's resuscitator in your resuscitation corner. So initiate in 21 to 30%, and if at all the baby needs positive pressure, use a TP's resuscitator to administer PEEP. Delivery room CPAP is of utmost importance. And again, post-stabilization, the transfer of the baby in a thermoneutral zone using a transport incubator and a TP's or a transport ventilator to transfer the baby to a unit. Having a controlled thermoneutral environment in the unit is again very important. Preferable to use a closed care system. An open care system is also well worth it. But it's mandatory that you stick on to the standards of temperature care in the NICU. And as a part of gentle care, again, we all know gentle handling is very important. So, you need to be very gentle with them. So avoid Trendelenburg position, avoid head down position, and head and elevated and midline positioning is important. Again, avoid rapid infusions or flow rates in the unit whenever you administer fluids or medications in the unit, because these babies are very prone for developing general matrix bleeds. And next thing and very important thing about gentle care in the unit is use of oxygen. So most commonly used drug in newborn is definitely oxygen. So titrated use of oxygen in the delivery in NICU is again very important. So there are various trials like Goose 2, which all justifies targeting the saturations to 90 to 95% in the unit. So again, more oxygen is more dangerous. So these are the things that we need to consider as a part of gentle care of a baby in the immediate postnatal period.
So one practical thing is, whenever this in your NICU, if the saturation goes down 88 or 87, you can see the staff rushing to the what happened, what is there. They will increase the oxygen, whatever it is, try to maintain it more than 90. But if it is, even if it is 95, 97, 98, 100, nobody bothers. That is the problem. You have to. So what one practical thing is, each and every crib put a writing. Targeted saturation is 90 to 95. So if it is more than that, if the baby is on ventilator, train them to decrease the oxygen. So now,
and one more thing to add to that. In the delivery room, again, saturation targets need to be given importance. Target 60 to 65% at birth, 80 to 85 by 5 minutes, and 90 to 95 by 10 minutes. So before that, oxygen is not to be used.
The word gentle has got much significance when you are taking care of a preterm baby. Because if the baby is to bleed, intraventricular hemorrhage is one thing which we don't want to happen to the baby. That will happen in the first 72 hours, 90%. So you have to be very gentle while resuscitating the baby. Thank you, Vishnu. Other next things we have to take care is thermoregulation as well as the newer concept of delayed cord clamping. Can you just elaborate on that, Dr. Binu?
Thank you, Dr. Nelby. Good evening, everyone. So, delayed cord clamping means we don't clamp the cord immediately. ACAG recommends that at least you wait for 30 to 60 seconds for clamping the cord. WHO has made a guideline that for 1 minute at least you need to wait. Many of the WHO documents that now are upcoming, they are increasing towards 1 to 3 minutes. Let us just hope that they don't make it 3 minutes. Although it will be advantageous to the child, the proportion of fights between the gynecologist and the pediatrician will go up as they make it 3 minutes. So now there is a new concept which is coming up in US and UK. The feasibility studies and the acceptability studies are being done about intact cord resuscitation. That is, they have a resuscitation table just near the introitus or on the side of the mother, where the cord is not cut, the baby is kept, and the resuscitation is being done. So intact cord resuscitation is one thing which is new and upcoming, and we may find new trials in India also. So now coming to the advantages, why do you need to delay the cord clamping? So in all term babies, it increases the iron stores by 50%, decreases the chances of transfusion by 50%. In preterm babies, beyond reducing the anemia of prematurity and decreasing the transfusion rates, it also helps in decreasing the IVH rate, it helps in decreasing the NEC rates, that is necrotizing enterocolitis. So one thing which comes to our mind when we see a delayed cord clamping is that will there be a polycythemia in the child? Will the child have more jaundice? So although there is a risk of polycythemia or neonatal jaundice, but there are no cases of severe jaundice or kernicterus, or no increase in symptomatic polycythemia has been found in any study where delayed cord clamping has been done. So coming to the thermoregulation part, it is very important to maintain temperature, especially in preterm babies when they arrive in the NICU. So one important thing is that you measure the admission temperature when the newborn comes into their ICU. Only then you will realize that how much is the prevalence of hypothermia in your unit. So for that, we should all ensure that the delivery room temperatures is 25 to 28 degrees Celsius. We must ensure that there is a thermometer inside the delivery room as well as the OT, where you can note the temperatures and ask the anesthetist or the technicians to switch off the AC when you come for a preterm delivery, so that the temperature is maintained at 25 to 28 degrees Celsius. Avoid air drafts in the delivery rooms. If there are open windows, avoid air drafts, close them. Pre-warm the radiant warmer to 100% heater output, that is for at least 20 minutes, 15 to 20 minutes. That is when you enter, and till the time when the baby will come out, it will probably be with 15 to 20 minutes. That time, pre-warm it, keep it in manual mode for 20 minutes, 100% heater output. And for babies less than 32 weeks, special guidance has been given by NRP latest edition that you can use polyethylene bags or wraps. So cling wrap is what we use in our unit. And Vigon also provides bags like NeoHelp for thermoregulation, in which we wrap the baby, and thermal mattress like Embrace, like the one you see in this picture. can also be used for transporting preterm newborns. Special care should be given that the preterm should always be transported in a transport incubator. You should switch on the transport incubator before you go for the delivery so that the temperature is maintained at 37 degrees Celsius when you come out with the baby and transfer the baby to your unit. Why so much hype regarding the thermoregulation? For every 1 degree Celsius rise in temperature, admission temperature to the NICU, the mortality decreases by 20%. So that is the hype, that is the concern with thermoregulation that we have.
Thank you, Dr. Deena, for the description. Two things to highlight. One is delayed cord clamping. Just one thing you have to remember is if you delay cord clamping by 1 minute, it decreases the incidence of forget about other benefits. It decreases about the incidence of intraventricular hemorrhage by 50%. Then you will be motivated for this delayed cord clamping. Second thing is what Dr. Deena has mentioned. For each decrease in temperature, mortality increases by almost 20%. One of our fellow had done study regarding this the temperature maintenance. What we have done is baby was transported in Ziploc as well as embrace. Multiple method was used, transported to our unit. Still the admission temperature was only 35.4. What happens is we are not measuring the admission temperature. Then we are not recognizing that problem. So first step for this is make it a habit in your NICU. The admission temperature should be recorded. Then only you will realize its importance. We'll move on to the next scenario. So this baby was transported in Ziploc cover and baby was provided with TP's resuscitator, that is respiratory support. But how will you give respiratory support for this 28-weeker, maybe 32-weeker? How will you proceed, Dr. Binu?
Basically now these things are quite well practiced now. The ventilation aspect should be done only when it's a necessity. We always go for CPAP or high flow oxygens. Now non-invasive ventilation is also coming into the thing. Various studies highlighting the benefit of one over the other. But for the current practice, CPAP is preferable prior to intubation and probably post-extubation high flow may be better or even non-invasive ventilation. So now regarding ventilation for these lung protective strategies, you don't ventilate it. The earlier teaching was like you had to get the carbon dioxide down as fast as possible and as much as possible. But now thing is permissive hypercapnia, you make it up to 65, the pH is more than 7.25. So the 7.25 is the extubatable pH. So anything more than 7.25, the pH is reasonable, you can still extubate and then give a support of CPAP or something. So maintain the saturations at 90 for small preterms and tidal volume of 4 to 6. Volume guarantee ventilation should be the norm. And then if the PEEP is the one which causes barotrauma. So if you take an X-ray for an hairy membrane disease, you see a low volume or a hazy lung, rather than jumping up on the PEEP, maybe going up on the PEEP may be more beneficial. So these sort of ventilation strategies where you don't give expandant, like you don't give more air at a time and then expansion and distension and contraction of the lung in all respiratory cycles, that will cause more of barotrauma. So try to minimize the expansions and maintain the saturations and keep the blood gases like PCO2 high, and then over a period of time the baby will generate endogenous surfactant and you will be able to get out of the ventilator. So that should be the norm. Ventilate as gently as possible. You don't see high chest rises in babies on ventilators. You make them, you see that they are comfortable, there is a minimal chest rise, and then that should be it.
Thank you, Dr. Binu. So one step to improve the respiratory, to decrease the respiratory complications as well as invasive ventilation, everything. If you ask for one step, that will be labor room CPAP with TP's resuscitator. The day before this introduction of TP's resuscitator in the labor room, we had to give lot of surfactants, these things. Nowadays, the use of surfactant has greatly decreased. So that point we have to remember, always give TP's resuscitators, CPAP in the labor room. So Dr. Binu was mentioning about volume guaranteed ventilation. Dr. Vishnu, can you just elaborate on volume guaranteed ventilation a bit more? Because that is one of the newer things which decreases the long-term morbidity. Can you elaborate on it?
So the standard of care or choice of mode of ventilation in a neonate, usually in the NICU, are pressure controlled modes. So, as we all know, ventilation is a very dynamic process, and as the compliance improves and the standards of the baby's lung improves, in a pressure controlled mode, there is a possibility that the excessive tidal volume is being delivered and hyperventilation happens. So there is a chance for volutrauma, paratrauma, and biotrauma. So in volume targeted modes, what happens is you set a targeted tidal volume. So around 4 to 4.5 ml per kg is what we set usually. You set a PEEP based on the pathology of the lung that we are looking at, and the auto weaning of PIP happens. So usually you set 20 to 25% PIP above the required levels. So once the baby's compliance improves, the PIP auto weans. So there is a reduced chance for volutrauma and barotrauma in volume targeted modes. So, and again, there have been a lot of evidence that supports the use of volume targeted modes in preterms, especially because they all have proven that it significantly reduces the incidence of deep bronchopulmonary dysplasia and all morbidities and mortalities. Significant reduction in mortality, significant reduction in intraventricular hemorrhages, incidence of periventricular leukomalacia, and the duration of ventilation also. Number of mechanical ventilation days also is reduced in volume targeted ventilation as auto-weaning is.
Thank you, Dr. Vishnu, for that.